I use my temporaries in the protocol that we teach and in the protocol that I use every day. My temporaries are blueprint for my finals. They have to be so damn nice that the patient is going to be happy to wear them for 3.5 weeks. This sort of high-end dentistry is not about getting them in and out. It's about spending the time with them, and you're going to charge appropriately for that. And you need to give, like for this cosmetic dentistry, it's not like they're coming in to get a tooth that's broken fixed or an endo done. It's like they're walking into Rolex and they're buying a Rolex. And the person, I hate this phrase, but like customer service, it has to be better than it ever has been.
This episode goes deep into temporary veneers. They can be really fiddly, they can be really stressful, and we discuss quite a few protocols that exist, but actually Aodhan Docherty, he's a sensation in Sydney and he does so many veneers, he does them so well. I've been intrigued by social media, and I told him he's got one mission today, and that's to go really deep into temporary veneers, because like I said, they can be a real source of stress for us dentists. The whole veneer process when we're starting out can be quite stressful, but one thing I promise you today is that if you listen all the way to the end of this podcast, temporary veneers will become so much easier for you. We explore some different protocols that are out there, some things that I've tried, something that he's tried, but we'll tell you the exact steps to make sure they get really nice, crisp temporary veneers, how to get them to stay on, how to shape them, and then how to remove them when you're ready to fit your veneers. This episode is eligible for 1 CE credit or 1 hour of CPD. Protrusive is a PACE-approved provider. As usual, you need to be on the Protrusive Guidance app. Head over to the website protrusive.app to get started. If you haven't already, you need a paid plan to get CE, but the education otherwise is free. We've been giving free podcasts for 6 years now, but if you'd like to show your support, please do consider getting a subscription, because that's what allows us and the team to grow and make good content for you. Every PDP episode, we give you a Protrusive Dental Pearl, and this pearl is taken directly from a really important thing that I learned from Aodhan. You see, it's so important that at the fit visit of your veneers, that the tissues are absolutely perfect. You don't want any inflammation, you don't want any bleeding. So whilst Aodhan does cover which cleaning tools he recommends his patients to use, the thing that I took away and learned is the type of mouthwash to use, because he's found in his protocols that it does reduce inflammation. The pearl is to use something that's chlorhexidine-based, but I know what you're thinking. You're thinking, okay, well, what about the staining? Well, turns out there are certain mouthwash brands like Curacept that are ADS, which is an Anti-Discoloration System. For me, this makes absolute sense because you get all the benefits of a really nice tissue response, so you get no bleeding and no inflammation on the day of your veneer fits. But again, you don't get any of the nasty staining that you can get with chlorhexidine-based products. So when prescribing or giving your patients a mouthwash to use in the interim, as well as all the oral hygiene instructions, consider prescribing an ADS system, which is an Anti-Discoloration System. So thank you, Aodhan, for teaching me that, which I'm passing on to you. And actually, this episode is absolutely full of gems. I'll tell you something interesting, guys. Just 2 days ago, I was diagnosed with a pneumothorax, a spontaneous pneumothorax. Essentially, my left lung is collapsed, and here I am doing this podcast. It was actually supposed to be yesterday, but I moved it to today, and I thought, let me see how I feel. And when I wake up this morning at around 5:30 a.m. to record this podcast, because our guest is in Sydney, I was like, oh, should I do this? Should I not? I'm feeling a little bit short of breath. But as soon as I sat down with Aodhan, and we just went all geeky, I absolutely forgot about everything. I feel great. And health comes first. Health is wealth. So why am I sharing this with you? I'm sharing this with you because when you do something and it doesn't feel like work, that is your true calling. Sometimes when I'm in the clinic, I'm just in the zone, I'm in the flow, and I don't feel like I'm working. So this didn't feel like work. I had such a wonderful conversation with him, and my shortness of breath, considering I've just had a pneumothorax 2 days ago, isn't too bad. The worst thing about this pneumothorax is that we've had to cancel our family holiday. I can't fly. And I just feel so bad for my children, because we were talking every day about how much fun we're gonna have in Dubai and all the water parks we can go to. So I feel devastated for my boys, but health is wealth, and there will be more holidays. And thank you so much, Protrusive, for all your messages of support on Protrusive Guidance when I told you guys this happened to me. But as you can see, I'm fine. Thank you so much for your concern. Thanks to my wonderful wife and my family for looking after me so well. And thanks again for you guys for your support. Before we join the main episode now, don't forget that in April, me and Mahmood are bringing back the Basics of Occlusion 2-day live course. We've actually rebranded it to Bulletproof Dentistry. We changed the name because delegates left with so much more than just occlusion. Yes, we had the 9 hands-on exercises and we had wonderful feedback, but delegates left with a set of protocols and philosophies for force management, for longevity, for how to make their dentistry bulletproof. So it is an occlusion course, but it's really a foundations of restorative dentistry. That course is on April 25 and 26 in the UK in Surrey. Previously, we've had delegates from all over the UK, as well as Estonia and Libya, Italy. So wherever you are in Europe or the world, we'd love for you to join me and Mahmood to do the course that you should do before you ever do a full mouth rehab, before you do any toothwear course. This is the foundations of occlusion and restorative dentistry. Check out bulletproofdentistry.com. That's bulletproofdentistry.com to learn more about our 2-day course. Hope you enjoy, and I'll catch you in the outro. Welcome to the podcast, my friend. I'm very excited to do a deep dive into temporary veneers, right? And so let's start with, you said a little bit about yourself in terms of you work in Sydney, cosmetic dentist. Anything else that defines you? That, why did you go into cosmetic dentistry? Why not oral surgery? What do you love about the field that you're in? And it sounds like you own multiple practices. That sounds very stressful.
Yeah, it'd be very stressful. That's dentistry though, isn't it? Just a stressful career. Seriously, you can try all you want to implement practices, protocols, and levels to things in terms of checklists and stuff. But there's always going to be that stress. It's a weird. I reckon dentistry is one of the strangest mixes of healthcare, business, and just this high level of work that you're doing on a patient in their mouth while they're most often conscious, right? Like, honestly, I don't think there's many other careers that juggle that sort of amount of variables. And when things go wrong, they can go wrong spectacularly. And you have to be able to back yourself. But also you have to be able to understand when you shouldn't take a case on. I think that's really important. And when to get help. When to ask for help. I do it all the time. If I need help with something, or if I don't feel like I can approach a case, I rather bring it to a group of my close colleagues, and we discuss it. We have case discussions, and that's one of the great things about dentistry is you are all in the trenches. I hate that phrase, but like you're in the the shit together, and you just have to be able to pull together and help each other out. Like I spent the 6-7 hours this morning with a group of 4 or 5 dentists, and we basically went through our cases, and we basically discuss the occlusion, how we're going to combat people with parafunctional issues, occlusal dysfunction issues, constricted chewing patterns, and all this sort of stuff. And I suppose I feel like I have always been someone who likes to take on something that's challenging. And I love science and I love biology. And I think dentistry for me was just the perfect fit. And practice ownership is a stressful thing, but it's so rewarding when you spend years and years building this practice and you have patients which come back to you and they feel like family, right? I think it's just so rewarding.
I think what I love you said about it is the community of practice that you need around you as well to help you thrive. It is a team thing, not only as a practice owner, but to be at the top of your game clinically, you can't do it alone. You need to listen to others. So often when I present a case that I'm stuck on to someone, it's like they show you your blind spot and say, oh yes, you know what, I didn't consider that, and that's a great shout. Sometimes you just completely miss it, even though you knew it, you miss it. And so great. And I love that you said that. I love that you spent the morning in that way. Just an interesting question before we dive into temps. What do you find as the peak stress, being the practice owner or like doing the 0.1 millimeter precision cosmetic dentistry on someone who's got expectations and hopes and fears and that kind of stuff?
Isn't that a good question? I always say it's balancing the staff and the dramas and God knows. There's always dramas. There's always people that have something. I touch wood. I say this and then it's all going to fall to shit. But right now is so golden for me. I've got a great front of house. My nurses are great. The team is like, do you know those times where you're just like, I need to appreciate the times. And then like sometimes someone leaves or there's a catalyst for something that goes on or something happens and, there's dramas and then you think, God, why am I doing this? But at the moment, I think for me, having a good team like what I've got right now is just allowing everything every day. I just love it. Absolutely enjoy it. But I think that's one of the hardest things as being a dentist and a practice owner is managing staff, managing the team and challenging people. And like this year, something different I did. And I know we're not here to talk about this sort of stuff, but there's something different I did is I sat down with each person at the start of the year and I asked them, what is it that you want to achieve this year? And I said, where do you see yourself in the next few years? Like, what can I do to help you? So my oral health therapist said, I want to get better at doing proximal fillings. And my front of house said, I actually want to pick up an extra day and I'd love to become a practice manager of one of the clinics. So if I don't have that conversation, what will have happened to me previously is they will either leave or they will have job dissatisfaction or they won't feel supported. And that's what these days that's what it's all about, really. You have to really support your team and make them feel empowered. It's not like the old days where you just tell them to sit in the corner and do their job, because they'll just leave. Especially in Sydney, there's so many clinics and there's a lack of staff since COVID. There's just such a lack of staff and team. They'll just walk around the corner and get another job in 2 seconds.
I think that really highlights you, my friend. You as the captain of the ship, someone steering the way, the culture that you're brewing. That's so important. I read something recently that the success of your business is the most important metric to use is how your staff feel on Sunday night. That is, if you're led by that metric, then I really like that. That was deep. So already you gave us a little snippet about you as a practice owner, as someone who is going to help your staff to grow and be fulfilled. So I absolutely love that. Now let's go to the meaty part, right? Temporary veneers. Many years ago, when I was first learning temporaries, I don't think it was specific to temporary veneers that this advice was given. But you've heard the saying that, you know, if you make your temps really crap, then when the definitive comes, the patient will love it, right? And I just don't think that there's a place for that in the veneers, because, you know, when they're paying so much money and they want the whole point of getting the veneers is that to look good, why would they accept looking like not so good in their temps? But there's that saying that, okay, maybe you do want your finals to be a level up. So how are you going to tackle that question, Aodhan? How good should your temps be?
Well, this is an awesome question, because that's what I was told as well, even in dental school, as a laugh, right, by the lecturers, but it wasn't. It was, they were being serious. Now, I use my temporaries a bit differently, I suppose. I use my temporaries, and in the protocol that we teach and in the protocol that I use every day, my temporaries are a blueprint for my finals. They have to be so damn nice that the patient is going to be happy to wear them for 3.5 weeks. Because I do my temps, which I'm going to discuss with you different methods of that, but I do my temps, and then 3 to 5 days later, we do a review. The review is basically to ensure that we have completed a facially driven smile design, because it is different these days. It's not like the old days where you send your alginate and you just write on your lab prescription 1.5 to 2.5 wax up. Totally different. These days, we facially drive the design. So I send a facial photo, and now, as of 6 to 12 months ago, I send a full face scan. So I have a ray face, and I actually send a scan of their whole head and an intraoral scan.
And this is of them like while they're at rest or while they're smiling, and then you like overlay images. Is that how it works?
Yeah, correct. So I'll take different sets of images, and I'll do different sets of photographs. You know, I'll take the Emma photo, so the repose photo. So I tell the patients to either lick their lips and swallow, or I'll tell the patient to say Emma, and then I'll take a photo, because we are able to set the maxillary incisal length based off that photo, either basing it on the canine being at 0, basically being right on the edge of the lip, as John Coyce teaches, or as Frank Spear teaches, having 2 to 3 millimeters, depending on if you're a male or a female, 2 to 3 millimeters of central incisor showing. For me, I think everyone looks good with about 2 to 3 anyway. A little more always looks nice, within limits. But I use those parameters to do facially driven smile design, and we can basically drive the smile design so we don't have canting, and we can actually build out volume. So I get a big Duchenne smile, like the biggest smile. So we've got an Emma smile, a Duchenne smile, and a social smile, which is right in between. And that Duchenne smile is crucial, because if you get a social smile, you can't pick up a lot of things like gingival tissue asymmetry. You can't really appreciate canting. You need to get them laughing, smiling, and it's the hardest thing to do in a dental setting, right? Because half the time people don't want to be there. But in a veneer, you know, in a cosmetic consultation, bonding, everything like that, I do the same protocol for all of them. They're excited to be there, they're happy, and you get them chatting, and, you know, you say things like, give me an aha, and then do a photo and think, or whatever it is, and all that sort of stuff. I get my nurse to make awkward jokes. You
feel like a photographer in the studio, like trying to say these remarks to make them laugh and give those emotions. But one of the cool things I've seen is video, right? You video it, and then you get those still frames, and that can help. The problem with that, I guess, is compared to the sort of resolution of a DSLR or something, or a mirrorless, you know, to get that highest resolution, you probably don't get that with the moving images. But I think there's a place for getting some video as well, to use some stills to capture the wide array of emotions. How do you feel about that?
I use that especially for gummy smiles, because for a gummy smile, they train themselves to not show the gummy smile, and they train themselves to have that lower lip sitting down. And then it's so hard sometimes to get them to smile and to laugh and things like that. You put the camera on and you just start chatting to them. You can take your photos above the camera, which is set below, and you don't even have to have like some expensive sort of camera setup. You can just have a tripod and a camera and just set it on record, and essentially just get chatting to them. And as they warm up as well, that's when you can get those. You might do it like, you might not want to do those photos and records right at the start of the console. If you're trying to like get a bit of rapport with the patient, you might do a little bit into the consult, for example. But that's a really good point. The video can be crucial to seeing that gummy smile, especially.
And so you're doing facially driven, which is the whole point of getting the blueprint, and that blueprint is going to then dictate the shapes of your temps. And you said that once you place the temps, which we'll go into deep, you bring them back a few days later. And at that point, how long do you book? And I imagine you're getting out the disc and the flowable, and you're trying to basically get it perfected. But what I'd love to know is, okay, how often do you need to do that? And how often the patients come and, you know what, that what's in my mouth now is exactly how I want it. Tell us about that.
I would say clinically, 7 out of 10 cases come in and they are loving it. And I'm going to obviously jinx myself saying that, but but if you go through, if you have a good lab, you work with your lab and you guys are on the same wavelength in terms of smile design, and you have a really good technician that focuses on facially driven smile design, and you give them good quality records, you're probably going to get it pretty close with the mock-up and the Temporaries. If they come back, what are they going to say? They may say, hey, I actually want to have these front teeth a little shorter. You get your red disc, you adjust them up by touch. Hey, can I actually have the lateral incisors a little bit shorter than my centrals, or a little bit longer centrals, and I get my flowable and I add it? Can I get my canines rounder, round it off with a disc, or pointier? Because a lot of my patients love pointy canines, and I add the point a little bit more defined, and then I use a red disc. But if I see, for example, there's a cant, or if I see that there's a lack of fullness on the 4s and 5s, I'll grab my flowable and I'll build it out on the 4s and 5s. I'll polish it, I'll adjust it. How long does that appointment take? Probably half an hour. I don't take any longer than that usually. If I was starting and I wasn't doing this, I do this 2-3 times a day for the preps that I've done in the previous days, I'll book off an hour. I'm always an advocate of booking off more time than you need, because it's when you don't book off enough time that, as we were saying before, the stressful moments happen. Something goes wrong. You're bleeding. The patient's gums won't stop bleeding, and that's when the stress happens, because you're looking at the clock, and that's when things aren't going to go right. That's always the way. It's Murphy's law. So I always book off a little bit of extra time, even if I finish half an hour to 45 minutes early. I'd rather have that time to do my notes and to actually get the patient sitting, chatting, post-op instructions, and make sure they're comfortable. For this sort of high-end dentistry, it's not about getting them in and out. It's about spending the time with them, and you're going to charge appropriately for that. And you need to give, for this cosmetic dentistry, it's not like they're coming in to get a tooth that's broken fixed or an endo done. It's like they're walking into Rolex and they're buying a Rolex. And the person, I hate this phrase, but like customer service, it has to be better than it ever has been. And you have to train your team for that, because otherwise, if you give subpar customer service, you're not going to have a good name. So we've got all those protocols, like we're talking about, to get that facially driven smile design right, so our Temporaries look beautiful. Now, they're never going to look shiny and the same shade, but they should have the same shape, canting, everything. We want them to be beautiful. And that gives your patient then 3 weeks while your technicians make the veneers to adapt.
Just to clarify then, when they come for that review appointment 3 to 5 days later, by the time they come to you, the scan or the impressions have already been taken and sent to lab. So your lab's already got the preps already. And what you're doing either is from that appointment, telling the technician, hey, the patient was already happy, I didn't have to touch anything, crack on. Or actually, I made a few tweaks. Here's my impression of scan. Let's do this together to get it right. Is that the way it's going, right?
That's exactly it. Do you know what I'd rather not do? I'd rather not say to the technicians, hey, I want this done, this done, this done, this done, this done, change my temps, change this, that, and that. Because I can guarantee you, they may get 4 out of 5, they're not getting 5 out of 5 of those changes. So just grab flowable and do it. Even if the flowable breaks off in those 3 weeks, it doesn't even matter. But at least, like at the end of the day, it's probably going to be fine. But if it chipped off, hey, it's not the worst thing. Or if a little bit of stain happens. But if you're able to make those changes, scan it, and I take a full new set of records, right? New photos, and I take a new ray face as well, then I can give that to my lab. And facially driven smile design, like, hey, these days it's amazing having this face scanner. But for the last 10 years, I haven't used a face scanner, or 9 years before that. For the last year I have, but the 9 previous to that I didn't. I always just used good photographs and either an alginate impression of my temps or a scan of the temps, which I've been doing for the last, say, 6-7 years now.
The only question I have on this, because I know someone's going to mention it in the comments, is when you're adding the flowable to, let's say, lengthen the teeth, are you aerobraiding, bonding, and the flowable, that kind of stuff? Or are you literally just drying and adding flowable and then curing and then maybe just disking it off and the patient goes home?
Yeah, a little bit of bond, just cure the bond, put the flowable, done. Like,
let's
we're not aerobraiding.
Let's not overcomplicate it.
Yeah, I'm not aerobraiding and doing all that stuff. If the patient came back and there was plaque and there was crap all over the teeth, something's wrong. You know, their oral hygiene instructions need to be very clear. I make sure that they have it clean at least 2 to 3 weeks prior to the prep visit, by the way. I make sure that they use a chlorhexidine mouth rinse for the week prior, and they use an anti-discoloration mouth rinse so they don't get the staining that we see with, for example, Curacept or Savicol. And their soft tissues need to be really beautiful pink. They need to use interdental brushes in the lead up or floss. And I scare the life out of them if they don't do it, because I say we're not prepping your teeth that day. And it would hurt me more than them, because I book off 3 hours for my prep visit. But we've got a mutual understanding, and the patient really wants to impress you at that stage, and their soft tissue should be healthy. You don't want to be like prepping teeth and there's bleeding and you start finding subgingival calculus and all that sort of stuff. You want to be prepping and there's no bleeding. You want to make it like a walk in the park.
Absolutely. And you mentioned about a non-staining mouthwash. Is that like a peroxide-based mouthwash?
So it's a chlorhexidine-based mouthwash. You could try a peroxide-based mouthwash. For me, my experience has mostly been with chlorhexidine-based, because I find that you can't use it long term, but for a short term use of a week or two, the soft tissues react really nicely. Like, they look beautiful after that. They're primed for your prep visit.
Okay, fine. So I think the staining worry that we usually have with Chlorhex, that comes for long-term use. That's why in the bottle it says avoid using for more than 2 weeks or 3 weeks.
So the trick is, don't use chlorhexidine mouth rinse that is a discoloration branded one. So I should say, they're not going to brand it discoloration, but there's one that's branded Anti-Discoloration System.
I didn't know that. Okay.
So, and God, do you know, someone asked me this about a month ago and I looked up the science and now I've forgotten it. But basically, it's, I don't know if you guys have the brand Curacept. Probably,
we do.
Right? Yeah. So there's Curacept that stains, and God knows why they have that. Then there's Curacept that isn't a staining, like it doesn't stain. So it's called Curacept ADS. And the ADS is Anti-Discoloration System. And that doesn't stain.
I did not know that at all. So that is a pearl right there. So yeah, excellent. Love it. Thank you so much for sharing that.
Imagine you got them to use Curacept and they come in and their teeth are bloody brown and they're all stained, and then you're trying to clean them and stuff like that. Or God forbid, the temps go brown, because they'll definitely go brown if they're starting to rinse with too much chlorhexidine. So use the ADS one, the Curacept ADS.
That is a top tip. Brilliant. And you mentioned about the importance of being able to clean around your temps. So let's go into the different ways that we can do temps before we learn how you like to do them, how you and Cam, etc. like to do them. Just a little take a step back and overview. I'll tell you a bit of a journey of me when I was learning temps, and it kind of covers the entire spectrum. And then I'd like to see where you fall on the spectrum, or maybe you do it in a completely different way. So the first time I ever learned veneers was from a restorative consultant in the UK, and his argument was that because we are staying in enamel, that we don't need temps. So that was the most extreme view, right? Because we're in enamel, we don't need temps. Obviously, the downside of that is you're not giving the patient that taste of what's to come. You don't get that constant validation like you do. Like, okay, is the shapes correct? Mr. Patient, are you happy with this kind of thing, right? So you miss out on that. But there is one argument that if you're doing very minimal prep, there are some challenges actually in making veneers. Like contact lens veneers, fine, but contact lens thins temps is a bit tricky. Before we move on, any comment on that?
I agree. I've got this in some bloody slides for you coming up, but you're doing all the slides for me.
You know what? Okay, tell you what. I'll stop talking. No.
I want to hear it because if there's something that I don't have in there, after this, I'm just going to open that and I'm going to add everything you said in.
This is just what I've learned over the years, and I just wanted to do a little overview because what I really want to know about is how you have found to do them. Mm-hmm.
Exactly. Like you've started at the right point. No temps. No temps is like, if you're doing minimal preps, which we all claim we are, right? We're all doing minimal preps, or we're trying to do minimal intervention dentistry, and we're not exposing dentine. So that's critical. You can't expose dentine and not do temps. Then no temps is a viable option. What's the biggest thing for no temps? Number one, soft tissues will inevitably be healthier. I guarantee you soft tissues will be healthier without temps. Even if you've got someone who is really good at cleaning their temps and really good with oral hygiene, the oral hygiene around something like a bisacryl or a temp material is never going to be as excellent because it's more rough, it's more plaque retentive. But number two is what you said, they can't visualize their smile. So if they can't visualize the end goal during the process, they can't adapt to it. So my ideal is that by the time the veneers come to fit or issue, the patient is like, they look beautiful. Thank you. Let's put them on. They're actually jumping out of the seat when they see their temps initially. And that's actually the big excitement for me, like for the patient, is when they see them at that stage, because that's when they've got totally different teeth. But when they get their final teeth, the color is going to be nicer, the luster and the shine, but it's the same design. And that's where you've got the adaptation, and you're going to have, like for me, I find that for my cases, majority I've ever done, and I've done thousands of cases now, and Cam that I teach with is done many, many thousands of cases, is that our cases with no temporaries, you're going to have a risk that the patient then doesn't potentially consent to cementation because they're frazzled or they're not used to it at that stage. Whereas if you give 3 weeks, like the 3-week rule as we always call it, for them to adapt, they're much more easy when it comes to the cementation.
The word adaptation, is a great one, Aodhan. The reason I love it is because, some people might think, oh, it's the occlusion or speech, and all those things are important, but actually the adaptation is not for them, it's for the people, their loved ones around them. Because I'm sure you experience, if you give someone, and I love what you're saying, because you give someone their final smile without a dress rehearsal, without that prototype, then what they instantly need to adapt to is they've paid their big bill, they're now got these beautiful veneers, which is what they wanted, but then people are like, oh, your teeth have changed, and sometimes they know it looks great, but that sort of is overwhelming for some personalities, right? And therefore can be very messy. But if you give them time to adapt in the temps, it's much better than actually getting to adapt in the defensives.
That's going on the slide, I'm adding that. It's so true.
Let's have a look at it, Aodhan. Share your screen. Let's bring the slides up. And for those on Spotify and Apple, we're not going to do a dirty one on you. We're going to be we're going to pretend the slides aren't even there. We're just going to talk you through it like we are. But for the people on Protrusive Guidance and YouTube, you get, Aodhan's got some lovely visuals and stuff. I've seen his work on social media, so I'm quite, he's got beautiful dentistry. You got to check him out. So to have some visuals for those on video is totally cool.
So what we want to see when you've done temporization correctly is you actually want to see little spaces above the proximal papillas, and those little spaces are going to allow you to feed an interdental brush, such as a Pixstar or any of the other interdental brush brands. But I use a Pixstar. I don't know if you guys have Pixstars, but
it's like a plastic one, right?
Yes, it's the smallest one. It's a little interdental brush, and I use the smallest one interproximally. And you should, when you've done your temporaries nicely, you should have a little space above, or incisal to, I should say, the papilla. And that's your space that you can feed.
Like a tiny black triangle.
A tiny black triangle. What happens if you don't have any space? You're going to have inability to clean proximally, and you're going to have a nightmare for your issue appointment, because one of two things will have happened. You'll have crushed your papilla, and you will actually induce necrosis, and you will actually induce an actual black triangle. And also you're going to have lots of bleeding. So it's not good for anyone. So you want to actually see a little black triangle, the smallest black triangle, to feed an interdental brush through. And what will happen...
Hey guys, have you checked out the Protrusive app yet? It's the ultimate tool for the geekiest and nicest dentists in the world. Basically, people like you. If you're a true Protruserati, someone who loves the podcast and wants to level up their skills, this is for you. On the app, you can access exclusive webinars like Verti Preps for Plonkers, so you can smash it Monday morning. quick and slick rubber dam with bite-sized videos to make placing that dam quick, slick, and stress-free. Sectioning school. Because, let's face it, extractions don't have to be scary. And RBB masterclasses. Perfect for kicking off your prosto journey with style. Oh, and you also get loads of other webinar replays and premium clinical videos to sharpen your skills on the go. So, what are you waiting for? Download the Protrusive app today and let's take your dental game to the next level. See you there.
And it's particularly important, Aodhan, just to point out that those people with very thin biotype, right? Like, even scarier to work on those patients, right? Because of the risk of recession. And you definitely don't want to go anywhere near the soft tissues of those kind of patients. It's less forgiving.
It is so much less forgiving, and that's important. Like, you have to, during your examination process, really identify, like we would go through a list of things, as I'm sure everyone does, but we would identify the type of biotype and the type of tissue that the patient has as well. Because, yeah, as you said, thinner biotype, more prone to recession. And that's a worst case scenario, is to come to the issue appointment and have margins exposed, and then you're re-prepping as well. And you started exactly right. Like, the three main techniques would start with no temporaries, where you've done minimal prep, you've got minimal dentine exposed, so minimal to no dentine, I would really say. So you're not going to have sensitivity, and that's going to be excellent for soft tissues, right? But you're not allowing the patient to test drive and really critique the final design. And
so, as a percentage, how often in your patient base, because it varies differently on where you are working in the world. I'm a huge believer in that your demographics will greatly change the kind of dentistry you have the permission to do on your patients. So, what percentage of your patients get a no temp approach because of their scenario that they're in?
0.0%.
And that's cool. It's good that you decided that, okay, this is a way, but for the reasons that you've already explained very nicely, that it's not in tune with the way that you'd like to do things.
Agreed. And it really also comes down to the test drive for the patient, the critiquing, the smile design, because there's only so much. The only other way you can do it really is, and I was speaking to Michael Allen, who is an excellent dentist over in Austin, Texas. We have a little beef on Instagram, if you've ever seen it. He's a great guy. Like, I was talking to him yesterday about his approach, and his approach actually involves doing the trial smile, which I do as well for a patient, but he spends all of the time at the trial smile appointment with the patient critiquing all of the factors that we spoke about, making sure that the incisal edges are at the level they need to be, making sure there's fullness, the shapes, the size, everything is bang on. But you have got a 1 hour, 40-minute appointment to do that. You don't have any time for the patient to go home, start adapting, get any feedback as well, and everything like that. So that's an approach you could use. That's the other approach. But I personally prefer to use temporaries for every single patient.
Mm-hmm. I like that.
Now, there's another approach, and it's the traditional approach, and all of us will have done this because we were taught this at dental school. Like, when you've done a crown prep, you use your putty key, you fill the material, you've probably put a little bit of glycerin or a bit of Vaseline on the tooth, you seat it. When it's just about set, you pop it off. Then you use a disc to shape the actual temporary, and then you cement it with some temporary cement. Now, you can do that for veneers as well. It's a little bit more fiddly with veneers because they're not full crowns and the prep should be light. So it's not the easiest thing to handle them and to adjust with a disc because
very flaky, very thin in my experience. And then, you got to choose your path of insertion because obviously with veneers, we're going usually horizontal, like labelly. Again, it's very fiddly to take it off and insert it in that way. But yeah, it's very much, you make a great comparison that it's how we are traditionally, learn to do temps.
And that's the way we all learn. And that's the way I did it for years and years, because that's all I knew. And that's, what did I find happened? I found like the downsides. Number one, God knows I would always use a disc and over reduce around the margins. And I would then go to seat it and I've got a deficiency. And then I'm trying to add flowable and there's flowable over the soft tissue. There may be bleeding. There's different ways you can re-add flowable to something you've over reduced, but it makes it very hard because the flowable can chip off at the margins in that few weeks that you're waiting for the finals to get made. I'd often either over or under reduce the interproximal. So I'd induce a very big I'd create a black triangle in my temps that's too big, or I would leave too much material interproximally. I would take it off and I would break a temporary. Like you said, it's super fiddly and super thin. Or when I would cement the temps, I would have excess that went subgingival or interproximal that I struggled to get out, and then I'd induce bleeding and it would be a mess. And then when I took those temps off later, I'd see lots of interproximal temporary cement. And that was my experience with doing the traditional technique. And that's why I don't do that technique anymore. I really only do that technique for crowns.
So this is another 0.0.
Yeah, 0.0. Nah, it's not 0.0, but it's closer to that. I literally only do it when I do crowns, because I feel like I can manage the traditional technique with a crown well, and I'll talk about the other technique we use, but I find it better than the next technique for a crown in particular. So if I'm going to do crowns on the posterior and veneers on the anterior, then I'll do my crowns with a traditional technique and segmentally make some temporaries using the shrink wrap technique for the anteriors.
And so the shrink wrap technique is the way that you like to do things, which you're going to describe now, right?
Yeah, so the shrink wrap technique is essentially where we are shrink wrapping the temporaries onto the teeth with our stent, and we remove the stent and we're not removing the temporaries to polish them. We are basically gluing the temporaries to the teeth, and then when we take our stent off, the temporaries are still on the teeth. Now, what are the questions going to be? Number one, how do you keep them on? Number two, don't they just pop off when you take your stent off? Number three, isn't that going to have lots of excess everywhere? Well, how do we get around that? I would say number one, you need an excellent stent. It's not your single phase, crappy, medium body, stent. It is going to be a light and heavy body stent, which is cut perfectly. So when we do our courses and things like that, we actually get the delegates. We show the delegates how to do this, and we teach them so they can teach their nurses, because it keeps your lab fees down and it's really easy to do. To make a really good stent makes your life so much easier during veneers. And a really good stent is good for the shrink wrap technique or the traditional technique as well, just by the way. So use a light and heavy body stent, and it needs to have little escape pathways interproximally, and those escape pathways allow excess to come out, and we need to scallop it with a fine blade. Usually an 11 blade is the best, and we scallop it around the gingival margins so it sucks in and sits at that gingival margin really nicely, and that's how you get crisp gingival margins for your temps using a shrink wrap technique.
When you load up the stent and you deliver it, there is a temptation to start playing around. How long do you wait in terms of nuance to actually wait for some of the initial set to happen before you start removing the scallopy excess? Because if you remove that too soon, then it might kind of disturb the rest of it.
Good question.
Do you find that when you're able to remove it, it kind of cleaves off at the right time, leaving the actual temp behind on the tooth?
So how about I walk you through the technique?
Yeah.
So step by step.
But before you walk us through, just want to quickly mention a few other ways that I've either done it or have heard of, actually.
Yeah.
One is the direct composite veneer. So spot etch.
Sorry, I've done that too.
There we go.
I'm going to add that in.
I thought you would have. You've got to update your slides, man. So tiny spot etch and a direct composite veneer. Again, it's using a lot of material. And again, you're not being driven by the future shape. You're just literally doing quick composite veneers. And for a fussy patient, it's difficult to get right. The other way, which I have used and probably is something that I've used the most, is doing it your way, the shrink wrap way, okay, except the putty is cut at the just incisal to the papillae. So basically 2/3 of the tooth, okay, so the incisal 2/3 of the tooth is exactly this way. And then the gingival third is with a composite veneer, basically. So it's like a hybrid. That's what Jason Smithson taught me on his course years ago. And that works well. Again, when I did the Dawson Academy, Ian Buckle taught me your way. So I feel as though what I would do now, I mean, I got an older patient base. I'm doing a lot more crowns. I'm doing veneers. But I do like the shrink wrap technique in terms of do it once, make it neat, make it nice, and you're done, rather than like a two-stage. But, the reason I mention it is because I want to give everyone an idea of there are so many different ways to do it.
There's many ways. And the way you learnt with Jason and that I've seen Pascal Magnier do it as well is by doing the gingival in composite. And it's not to say it's a bad technique, right? But the idea you controlling where your margins are with composite and also controlling the interproximal, in theory, is a good idea. However, if you have any bleeding around the gingiva, it can be a bit of a pain because you're struggling to control bleeding while you're trying to place a composite onto those areas. And I feel like with the shrink wrap technique, the control we have with a really good stent is so much better than trying to place it by hand around the gingival margins, because the stent will crisply suck onto the gingival margins and hold your material there while you actually use something to clear the interproximal. So you don't need to rely on your manually working composite around those interproximals. So
agreed.
Essentially what I do is we've got our preps done, we've done our scan, and we have our cord in. Okay, I take my cord out, I get the patient to rinse, and I take 5 minutes. Why? So, because when you take cord out, there's always going to be a little bit of bleeding, probably here or there.
It's that compression. It's a release of the compression. People get worried. Young dentists, when they remove the cord or the PTFE or whatever they're using, and they see that bleeding, they get very worried. But actually, it's to reassure everyone that this is a normal phenomenon due to this kind of decompression of the capillaries.
100%. It's totally normal. We're trying to reduce basically bleeding and gingival crevicular fluid with that. And it's been usually we try and we limit it from 8 to 15 minutes, like in an ideal world. We all know we all do it longer than that, but like that's your ideal. You shouldn't have cord in too much longer. You've got a higher risk of recession and things like that. But as soon as you pop that out, everything opens, you can get bleeding. I set the patient up, have a rinse, have a little chill, go on your phone. I say, this stage you don't have any temporaries on. You're probably not going to want to look at your teeth and start doing selfies or anything silly. But just take a few minutes. I just go and get a drink of water. That's when I'm pretty tired at that point, and I go and get a drink of water. I flick through Instagram for a couple of minutes. I come back in the room and I'm ready to go. And I lie the patient back and I've got my Optrogate in, or like whatever retractor you use, and I spot etch the center of each tooth with a spot. And I'm talking about like I put etch onto my glove, or my nurse puts etch on my glove and hands me a probe, and I dip the probe in etch, bop, 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 and I add a little dot of etch into the center of each tooth. And that etch is then able to spot etch a certain area only. So you're not blanket etching the whole tooth. And then what I do is I actually pop Teflon strips into proximally. And that holds over the papilla and basically covers and protects your papilla. So these little Teflon strips, they're actually the thickness of a bit of Teflon floss, like your Oral-B Glide floss. You can use that as well. We actually place those over the papilla as a protection, and then I actually spot bond. And what spot bond am I going to use? It's a total etch adhesive, meaning it's something like an OptiBond Solo Plus, which allows us to just spot bond that area. So don't use a universal or something that goes everywhere. Spot bond after you've spot etched with a total etch. So that means that you're going to just etch the center of each tooth. And that is actually going to form a retentive bond to your temporary material. And that's how we basically keep the temps on, because the temps are going to shrink wrap into all the nooks and crannies and basically hold in. But if you spot etch and spot bond in the center of each tooth, then it's going to give it that extra grab onto your actual preps.
I was very scared of doing this years ago, but when Ian Buckle taught me on Dawson, it made so much sense. But initially, I was like, "Oh my god, why am I using bond?" But the other thing that you do, obviously, you show us the photos and stuff, is I was taught to take a photo of exactly where you place the etch, so you know your plan of attack when you're going to remove the temp. Usually you try and do it in the middle anyway, but it's nice to, sometimes different shaped teeth, and the abutment might be higher or lower, and so you know exactly where the etch is, and you reference back to that photo so you know roughly where it's the strongest bond. But I'd love to know, how do you actually come to remove it atraumatically before you put those veneers on?
Yeah, good question. I suppose in terms of removal, we're going to use a carbide point, and I section in between the facial surface, right down the midline of the tooth, across my spot etch point, and I open the interproximals. If I have got open interproximals, I open those up with the carbide point, not a diamond ever, because we don't want to cut tooth. And you can't cut tooth with a tungsten carbide point unless you're doing something insane, like you're pushing it through the tooth. It's going to hit the tooth and just spin otherwise, and you'll smell it burning if as opposed to holding a diamond and just prepping straight through the temporary and through your prep. So use a tungsten carbide, use it lightly. As soon as it hits the tooth, it's going to stop. I do it right in the center, and then I do the interproximals. And then what I do is I get a flat plastic or a cord packer, and I actually just go through and I tell the patient, listen, you're going to hear little pops here, little clicks, and I go through pop, 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 and I pop them all off. And I use a scaler as well, especially on your premolars, and I pull from the palatal cusp, from that buccal cusp, from the palatal aspect, and I pull it forward and I just pop all the temps off. If you've got,
and then what about the residue? The common question is the residue of where you spot bonded. Is it a soft flex disc? Because I quite like using soft flex to just polish that away. But is there anything else that you use? Maybe you use attachment removal burrs, or
I just run the tungsten carbide over the top of it, and I'm not changing the tooth anatomy doing that. And then I also air abrade, air particle abrasion. It's gone. So I actually don't use a disc personally or any diamond at that stage, because I don't want to change the anatomy and that intimate fit the veneer has. Even if it's only a couple of millimeters, I want to keep the most intimate fit possible. And you can also change the optical perception of shade and value if you go too hard with a burr right in the middle. If you actually dish out, because you're going to have thicker cement layer technically, especially if you use a white cement or a lighter colored cement. So that's pretty critical, is to do the most atraumatic removal and keep your instruments away from the gingival margin. But that gingival margin, those tissues should be pink and healthy. Why? Because using the spot etch and spot bond shrink wrap technique with something like Teflon is going to actually cover those proximal papilla. And I'm holding my stent on and I'm actually allowing it to go tacky before I remove the excess. Like you asked before, when do you remove the excess? I actually hold the stent, and then I have a probe and I just check the excess every so often that forms just apical to the stent, like just under the lip there. And when it becomes tacky, I just flick it straight off. And if you've got a really nicely cut stent, the way it flicks off is you get little scallops and they all come off at one. Even if it comes off in a couple of pieces, it doesn't
very
tear.
satisfying.
It's so
almost as satisfying as giant bits of calculus.
Because it comes off in a scallop, and it doesn't take, if you've got a good putty key, this comes back to that light body and a really well adapted putty key, it doesn't take from under your like beyond your margin.
Because you have a lovely tight seal, and so it kind of stops the material from being like a tablecloth being slipped under or your sort of, that magic trick they do. It's not going to be like that where everything just gets sucked away. It's a nice tight seal.
Definitely not. It's a nice tight seal. And the thing is, just before you are, like at that stage, just before you remove that excess, I actually take all those Teflon pieces, because my nurse will have cut up 10, 12, X amount of Teflon strips or Teflon floss that is sitting interproximally over the papilla. And I actually remove it and I pull it out and I pull it down against the stent, and that allows the papilla to bounce back into the interproximal area. And that is the Teflon is the critical step for this whole thing. If you use Teflon, you're not going to have to get a burr and go interproximally later to start opening it up. You'll have this beautiful open interproximal area with that tiny little black triangle we spoke about, where you can then push your interdental brush straight through, and you're able to minimize the trauma you cause by your own handpiece, and you can minimize the trauma the patient causes later if they're trying to jam one through there.
That was such a brilliant, detailed description, right down to exactly which burrs used. And those who are listening on Spotify and Apple, we respectfully did not mention any visuals, but if you want to check out the video later, then actually you can see the exact burr that Aodhan was referring to. He's given it all away. He's not hiding anything. He's being very frank and very educational here. So I now know your protocol to a T. It's wonderful. Everything makes sense, and all the little secret nuances of the Teflon as well. That was golden, man. Thank you so much for describing all that plus the visuals.
It's a total pleasure. Like when you're doing your cleanup as well, just some last tips for you if you want. Last things would be the cleanup. Use your pointed carbide, a tungsten carbide that is, around your margins. Don't use any diamond burr. Your pointed carbide will only remove temporary material. It will be atraumatic to the soft tissue, and it will not cause damage to the prep. On the palatal, use an egg-shaped carbide to clean up the excess. And then the big thing is, what handpiece is everyone using? because I haven't prepped with a high-speed handpiece in 11 years now. Always prep with a red band torque-controlled handpiece if you want really sexy preps, because it's torque controlled. It's not going to go from 0 to 100 and just cut into your margins. Your electric handpiece, your torque-controlled handpiece, will give you such a smooth, beautiful prep.
I mean, no doubt you'll cover this on the courses, but at this stage, have you given have you given LA yet? Because what's next to come is actual try-in of the veneers and stuff. So do you give the LA so that you can remove the temps and then try on the definitives, but then you mess up the lips? So how do you do the timing of the local anesthetic if needed?
Yeah. So when it comes to insert, number one, I've given LA. I don't say I give a small amount, but I share a couple of cartridges around the arch, maybe one or two. So I'm aiming to numb the patient and not overly numb, because when I go to properly insert or when I go to prep, I give a stack of LA. I give 4 or 5 cartridges. I don't want the patient to feel a thing. I want them to be numb for the 3 hours, and I don't have any hesitation in making sure they walk out with their lip out here. But for the issue, as you said, it's critical. Like, you want them to assess it properly. So I give them 1 cartridge kind of spaced out around so they're numb for when we get the temps off. I air particle abrade, or I pumice if I don't have air particle abrasion handy, but I'll air particle abrade to clean residue. I look in my mirror and I look visually with my head down so I can see if there's any little spicules of temps that will cause a misseed. And then I try my veneers in, and I then will do a full try-in process. I've like a very strict protocol of how we do try-in, and then I have the patient view them, and they're probably starting to get their soft tissue feeling back at that stage, like they can move their lip a little bit. The other way you can do it, as my colleague Cam often does, is he doesn't really give much LA at all. But for me, there's always going to be a little, like we all know, there's always going to be a little bit of discomfort removing temps. If you've got any dentine exposure, it's probably going to be on the cervical of a canine, for example. So you can maybe just give a little bit of LA there. But I often give some LA for my try-in, but not much.
Okay, no, it's good to know. And Aidan, you've covered all my questions there in terms of the technique. So, I mean, I know you're coming to London. It's very exciting. I personally will be in Copenhagen on some sort of occlusion symposium, but I'd love for people to learn about what you and Cam have in store. I mean, you guys just heard now the wonderful, no holds barred, like fully covered temporaries and how he does them. And I think a lot of people feel confident with that, but there's so much more to it in terms of assessment, bonding protocol with cement, etc., etc. So give us a flavor of what you have in store for delegates in London. And is this the same course that you do in Australia?
It is, yes. It's our Australian course. We've taught now 600 or 700 Australian dentists this course over the last few years, maybe more even. It is, and for reference, we've only got like 15,000 dentists here, so it's a fair whack of the population of dentists. But it's a course we absolutely love and we're passionate about. Besides dentistry, this is the number one thing I absolutely love doing, is teaching. And this course I promise you, number one, you're going to be absolutely exhausted by the end of it. A good exhaustion, because we bring our whole team over. So for us, it's not just me and Cam, two people. I've been to courses where there's 30 people to one person teaching, and you don't get any one-on-one time or minimal. And you don't get your preps checked properly. We've got 4 to 5 people who are going to come for this course. So you're going to have an amazing ratio. There'll be like 1 to 3, basically. You'll have someone with you the whole time. And we're going to check the preps. We're going to check the temps. We're going to start from up here and go through the whole thing. We do consultation. So we talk about how to essentially run your consult from the phone call, that the patient makes, or the initial communication, all the way through to them coming in the clinic, through to how to actually take records, structure the appointment. Like, every single bit of the appointment is broken down by time. So we record our appointments, break it down, and we show the candidates. And my idea is that I want you to run your consults the most effective way possible with the time you have. So I'll show you what you need in terms of how much time to allocate to each part, and then how to make the conversion, because dentists are notoriously bad for not being able to make the conversion. So we want you to do this dentistry. We don't just want you to be able to prep plastic teeth. We want you to go out and actually do it in real life. So we teach you consultation. We then teach you how to do the smile design itself, how to communicate with the lab and use Exocad and other technology to create the facially driven smile design. We go through motivational mock-up, which we call the trial smile. So the trial smile and all the types of preparations. So type 1 to type 4 preps with cases we go through as well. And then we actually get you to prep teeth. And we spend a hell of a lot of time on that. So more than half of the course time is spent on actually working on the teeth, like on the models. Because I've been to a lot of courses and we do all this theory and we don't really get enough time to do the practical. And that's something we didn't want to happen. We want to balance it perfectly, that you walk away with the knowledge and the practical hand skills as well. So we actually show you how to prep, and we do different prep types. And then we show you how to temporize, and we actually temporize the models as well.
Using the technique
and
that
we
you
go through how to then assess the temporization. Exactly, yeah. How to assess it then when the patient comes in, what to look for and what to adjust and how to adjust. And then we go through the issue appointment, the cementation and the try-in. So I teach you guys how to try in, we teach you guys how to do cementation properly, and we go through material science, which sounds a little boring, the material science, but it's actually super, super new. It's like using the best new literature for how to bond a precious metal, how to bond zirconia, how to bond lithium disilicate, whether you have Emax or Lissy. We go through how to do it on the actual restorative material and the tooth and how to join them together. And then we finish with actually aftercare, post-op and maintenance.
And no doubt that in the consultation part, you go through consent and consent forms, that kind of stuff.
100%. It's so important. And also we go through social media as well, how to market yourself, but how to do it in a way which is legal as well. And what to show patients, how to interact with patients, and how to really tailor your Instagram to be able to capture it, like capture that patient audience. For me, now for the past 4 years, I haven't seen anyone who's called the clinic, who has walked into the clinic. I've only taken bookings strictly from my Instagram page, which I never thought was a thing. I always thought that it's such a weird world, right? But I've built, a pretty decent little audience, and that's how I get all my patients, is just through social media. So we want to give you a flavor for how to do that too, and what to use to market as well.
Do you share any failures, you and Cam?
Yeah, well, we've got preps of because sharing failures is critical, right? You can't just learn from these sexy cases you see, these beautiful things on Instagram. You're going to learn from seeing failures and what not to do. So we've got stacks of preps from our early days. We've got preps from our lab, because for my own personal lab, we've got a lot of preps that come in, and they will take photos and things like that of the models. And this is like what not to do. Don't extend your prep here. Keep it facial. Do this, this, and this. Don't go too subgingival. But you need to see failures, and you need to see cases that didn't quite work out, whether it be invaded biologic width, because we have a whole talk on how to crown lengthen and soft tissues. All of those sorts of things come to give that full picture. I respect you a lot,
man. I was hoping you would say that, and I'm glad you did, my friend. And that wraps up an absolutely brilliant podcast. It's the first time I've gone deep on just veneer temps, and you did such a wonderful justice. The dates for your course on the website, please, because there's so many audience in England as well, and I'd love for them to learn from people like you and Cam. Website and dates, please.
Yeah, we'll chuck that straight up on the website. Minimax.com will have the seminar link and the dates for the course. Do you know what? I don't want to give the dates.
I think it's May, because that's when I'm going to Copenhagen.
It's the end of May, but I think it's 23rd.
I remember looking at it and thinking, hey, hang on a minute, I'm in Copenhagen. So I'm in Copenhagen 22nd, 23rd of May, and I think, yes,
it's the end of May.
But it's not the last weekend, because May's got 31 days, so it's like the second last weekend of May. But we'll put it in the show notes, and we'll have the link so you guys can check it out.
So nice. And follow us on Instagram. If you've got questions, do you know what? I'm always an open book. A lot of dentists will contact and ask things, or say, hey, how do you do this or whatever. Even if you can't make it to the course, just give us a shout and just give me a message. I'm always happy to help. If you've got an issue, I'll try and give you a hand or give you an opinion on what I would do. I'm not the be all and end all for this sort of stuff, but we do a lot of it. So I can give you an idea of what I would do in that situation, or where I wouldn't do, or where I've gone wrong previously. So I'm always
Amazing.
happy to have a chat.
Wishing you and Cam all the best in your trip to England. You've been to England before, or is it your first time?
I've been before. My mum and dad are from Scotland and Ireland, and I've got family all over the UK as well. So yeah, it's like our second home. So I'm really looking forward to going back. It's been a few years. So yeah, I absolutely cannot wait.
Amazing.
Do a little tour
wishing
around.
you all the best. And again, thanks so much for sharing so passionately, so deeply. It was real good fun. Really lovely geeky chat. These are the ones I love. I just love going deep in detail, and you did that so wonderfully. And also appreciate our chat at the beginning about, the stress of practice ownership and how our career can be stressful. It's important to hear different perspectives on how we cope and your leadership and how you're brewing the culture. These little things are important for everyone to hear. So, Aodhan, thank you so much, my friend.
I really appreciate you having me on, and it's been an absolute pleasure.
Cheers,
I'll catch you later. Thank you so much.
Well, there we have it, guys. Thank you so much for listening all the way to the end. How good was Aodhan, right? He was absolutely brilliant. So if you're meaning to go on a veneer course and that May Day is looking tempting to you, do show your support to Aodhan and Cam. Go and learn from them. I am always happy to support clinicians who give everything away, who are happy to share everything, who are happy to share their failures. These are the kind of clinicians that I really love and like to support. I'll put Aodhan and Cam's Instagram links in the show notes, as well as a link to book onto their course. If you're watching on Protrusive Guidance, scroll down, hit the quiz, answer 80% correctly, and get a cheeky certificate, 1 hour of CPD or 1 CE credit. Because let's face it, I'm hoping you learned so much from this episode and you feel confident with certain aspects of veneer temporization, thanks to the wonderful job that Aodhan did. And so you deserve a certificate. So if you like this idea of listening to the podcast or watching the podcast and collecting certificates as you go along, please do sign up. Please do join a paid plan on Protrusive. It's tax deductible, and I truly believe it's one of the best value education you can have, especially because now we've got the full 7-episode series on vertipreps for plonkers. That's all on the Protrusive Guidance app. If you enjoyed this episode, do not leave without hitting that like button, hitting that subscribe button. Even if you're listening on Apple and Spotify, please hit that subscribe button. It really does help us. Thanks so much, guys. I'll catch you same time, same place next week. Bye for now.